anterior bladder wall tumor. After I think straight away I'll go on with it. That is the tumor. It is slightly big in size in this particular case, which we had recorded shortly. And if the tumor is big, as the talks earlier have been given, there should be adequate imaging. In the beginning, as another speaker mentioned, we obviously need to do a very good survey of the urethra plus the bladder. And as you saw here, we saw this tumor and at a convenient position, or we start from the periphery where the tumor is less thick if the whole thing is solid. And if the tumor is totally papillary, then we can start it at a convenient area where we think we can come, usually near the peripheral wall, where we can come to the normal baseline bladder wall. So as we start the procedure, we keep the bladder semi-full, and then as required, because of the reach which needs to be at the far end from the urethral side. So as we cut, we have to reach the bladder wall level, which is the normal level with our cuts, and cut should be adjusted uh, in proper directions and probably in proper thickness. If we see the tumor which is too large, we can take full loop cuts, and if we see the tumor which sometimes maybe just a carpet like, we have to use the tip of the loop to cut in monopolar. So sometimes during the cuts, this was a large tumor and almost the movement is not realized a little. But as we are going deep here, and there is a pressure which has to be kept on the lower abdomen sometimes to bring the contact of the loop with the tumor. One important thing in an anterior wall practically is that the cuts also need to be timed with the bladder movement. So why I say that, in general anesthesia, the movement of the abdomen is uniform and controlled. And as you are going to cut the anterior wall, things are going to move. In spinal anesthesia, it seems it is slightly more difficult. The patient can breathe differently at times, and sometimes they can cough too. Hence, we need to take care when we are doing an anterior wall under spinal anesthesia. Sometimes the bubble at the dome or the junction of the anterior wall with the dome can be present, and it may also trouble us. So it can be either removed manually, or the air can be removed manually, or by altering the position of the patient and the table, either head up low or tilt on either side. And as you see, we are going deeper in this case in the tumor. There are some muscle fibers which are seen. And once the tumor is cut, the deep tissue or the muscle is to be excised. There you can see nicely the muscle fibers, and this would be obviously sent separately. Ideally, for the whole base of the tumor, this kind of deep resection is to be done. It is most ideal. Some people even describe it as a near perforation kind of a resection, which may be needed. And as we come to the end, finally, we need a good hemostasis. That's it actually. So as the video goes on, any questions or any discussion, we can go on.
Two questions, Ganesh.
Yes,
Jitain
sir.
had just made a comment a couple of presentations back that he starts from the middle rather
Right.
than from the edge. I feel that starting from the edge, you get a assessment of the depth where the bladder, normal
Yes,
bladder
sir.
wall is. So, what is your
So,
view on that?
so my take is that if the tumor is absolutely in size varied, then it is worth sometimes taking some cuts in the center. Otherwise, I would always go from the edge, and it always seems better to go that way.
And how important
I
do you
mean,
think is a
coming from the
70-degree
edge,
telescope?
you will realize as you come in, you get the bladder wall nicely, and you get the further cuts you can take nice deeply, because you always know where is the edge and where is the tumor. The 70 degrees I didn't get the
I know.
question.
I thought when you are dealing with a tumor on the anterior wall, especially closer to the bladder neck, how important is having a 70-degree telescope? Or you can manage
So
with a
70-degree telescope is always important in the initial assessment. Actually, how near the bladder neck, how acutely, where we are going to see the extent of the tumor. While resection, however, we have to rely on the 30-degree and
Yes,
keep the bladder variably empty so that when we press from the top, we can still visualize almost ahead of
till
the
the
bladder
bladder
neck.
neck. Yeah.
This we have seen, unless it is an obese patient, it is usually possible.
Yeah, in an obese, it's very difficult to press and get the
Yeah,
bladder neck into view.
neck. So still we do manage, but it is sometimes not possible.
Thank you, Ganesh.
Thank you, sir.